This session is titled Hypertension Cases. My name is Dr. Ajay Singh. I'm a member of the Renal Division of the Brigham and Women's Hospital at Harvard Medical School. These are my disclosures. So the first case is the case of a 66-year-old Black woman with diabetes who has persistent hypertension, despite being treated with 5 medications. These are listed: lisinopril 40 milligrams per day, amlodipine 10 milligrams per day, furosemide 40 milligrams BID, metoprolol 50 milligrams a day, and diltiazem 120 milligrams a day. She's asymptomatic. On exam, her blood pressure is 164/70 millimeters of mercury. She's non-orthostatic, heart rate is 54, but she's otherwise remarkable. She tells you that she measures her blood pressure carefully at home, and it's usually in the 160s at home. Which one of the following next steps is most appropriate? A, increase the dose of a diltiazem to achieve better blood pressure control. B, educate her about self-monitoring or self-treatment and see her again in 2 months' time. C, set her up for ambulatory blood pressure monitoring. Or D, start her on a blood pressure polypill to improve compliance. And so the correct answer is educate her about self-monitoring, self-treatment, and see her again in 2 months' time. Let me just give you some background to why I think this is the correct answer. Option A, increase the dose of a diltiazem to achieve better blood pressure control. Not the right answer, because she's already being treated with amlodipine, a calcium channel blocker, which in fact is a much better treatment option for a calcium channel blocker in terms of anti-hypertensive action. Diltiazem does have anti-hypertensive action, but they're mild. And one should really not be using both amlodipine and diltiazem together. What about C, set her up for ambulatory blood pressure monitoring? Well, certainly it's a consideration if one thought that she might have white coat hypertension or masked hypertension, and I'll describe some of these states in a minute. But look at her history. She's asymptomatic. On her exam, her blood pressure in clinic is 164/70, but she tells you that her blood pressure at home is in the 160s as well. She's non-orthostatic. The likelihood is that while, yes, she does have refractory hypertension, she probably doesn't have white coat hypertension or masked hypertension. D, start her on a blood pressure polypill to improve compliance. This is a really nice option because it's true that if perhaps compliance is an issue. And so if you reduce the number of medications she's being treated with, her compliance with the medications might improve. But the truth is, polypills are really not available in the United States, not usually very commonly used in many other parts of the world. So while it's a nice idea, not really practical at the present time. So let's look at different types of hypertension. So in this schematic, you see 4 different types: white coat hypertension, sustained hypertension, true normal tension, and masked hypertension. She doesn't have true normal tension, that's for sure. Her blood pressure in clinic is in the 160s. The truth is she doesn't really have masked hypertension, which is present in about 5 to 20% of patients, because again, her blood pressure is in the 160s. White coat hypertension, you expect her ambulatory or home blood pressures to be on the low side and her clinic blood pressure to be on the high side. And as we discussed, this is really not likely. And so while these are nice considerations, the truth is this woman has likely a condition called sustained hypertension. Now, just reflecting, does she have risk factors for white coat hypertension? Yeah, she's on the older side, age greater than 60. She's a woman. We don't know anything about whether this is a morning clinic visit or not, but people who tend to have white coat hypertension tend to have morning clinic visits. Blood pressure taken, meds taken in the morning versus PM. Yeah, she does have a number of her QD medications, but the history doesn't give us any signal or sign that that she's taking her blood pressure medications in first thing in the morning. Is she obese? We really don't know that. Is she an active smoker? No, don't know that. Diabetes, certainly a risk factor. This is an interesting study. It was published in The Lancet in 2018, and it's called the Tasman-4 study. And I think it's worth just going through this for a few minutes. The question that was asked in this study was, does self-treatment through self-monitoring of blood pressure result in greater control of blood pressure? This was a parallel randomized controlled trial in the United Kingdom among 142 general medicine practices, so GP practices. The entry criteria were hypertensive patients over the age of 35 with blood pressure greater than 140/90. The demographics of this patients in mid-60s in age, a mean BMI was approximately 30, mean blood pressure was 153/86. And about 60% of the patients had another condition present. So very similar to the case that I presented. They enrolled 1,182 subjects, so a good sample size, and they compared self-monitoring of blood pressure, which they termed the self-monitoring group, to self-monitoring of blood pressure with telemonitoring. They call this the telemonitoring group, or usual care using clinic blood pressure. This is they termed the usual care group. The primary outcome was clinic measured systolic blood pressure at 12 months after randomization. What they found, what they observed and reported was the titration of anti-blood pressure medications using self-monitoring with or without telemonitoring significantly lowered blood pressure. The benefit, in fact, after just 6 months, was a mean reduction of 4.7 millimeters per mercury, mean reduction. So that means in some patients it was even greater than that. Obviously, in some patients it was less. But the benefit with self-monitoring after 1 year was a mean reduction of 3.5 millimeters of mercury compared to usual care, which is important because it suggests this effect of using self-monitoring is a sustained effect, not just a transient effect. And there really was no significant difference in adverse effects that were observed. And you can see that it really, when you look at this forest plot, that all the different patients in the self-monitoring versus usual care, all the patients benefited regardless of their demographics, whether they were under 68 or over 68. Generally, women benefited more than men did. And many patients who had some comorbidities also benefited. And this was also true when you compared telemonitoring versus usual care as well. Now, what about the data around polypills? This is the paper that was published in the New England Journal of Medicine. This was published in September 2019. Here, in this paper by Munoz and co-workers, there were 303 adults that were enrolled. 96% of the patients were Black. 75% of them tended to have an annual income of less than $15,000. It was an open label single center study. They compared usual care versus a polypill in the and you know, the medications they were using was amlodipine, losartan, hydrochlorothiazide, and atorvastatin. And in fact, what they found was there was a significant reduction in mean systolic blood pressure in the polypill group, which approximated around 9 millimeters of mercury versus 2 millimeters of mercury in the control arm, which was highly statistically significant. And you can see this in the figure A for systolic blood pressure on the bottom right-hand side of this slide. So in case one, the correct answer, educate her about self-monitoring, self-treatment, and see her again in 2 months' time. Low risk, not many adverse effects, seems to be a sustained benefit. Keep in mind that ideally, if and when a polypill comes into use, that's something to consider to improve compliance among patients. Case 2. You see a 58-year-old white male with a history of hypertension. Patient does not have diabetes mellitus. Kidney function is normal. You see that, BUN 18, creatinine 0.8. Being treated with amlodipine 5 milligrams a day and lisinopril 20 milligrams per day. Systolic blood pressure in clinic is in the 140 to 150 millimeters of mercury range. Home blood pressures when measured are in the same range. So physical exam is normal. Blood pressure in the clinic of 155/88, heart rate 78. So the options are, which of the following is the most appropriate next step? A, his blood pressure is satisfactory. B, his systolic blood pressure can be further reduced to a target of less than 140. Or C, his systolic blood pressure can be further reduced to a target of 120. What's the correct answer? So the correct answer is suggested by this study, and it is the correct answer in this case is C. his blood pressure can be further reduced to a target of 120 over, less than 120 over 80 for a number of reasons. One, because the patient doesn't have diabetes, and so the results from the SPRINT study, which I'll discuss in a minute, are pertinent here, and the patient seems to be otherwise well. This patient does not have white coat hypertension because home and clinic blood pressures are very similar. This is the SPRINT study, and it's an important study for you to know. Very, very rarely do we get studies with such impressive results, where it's absolutely clear that there is a benefit of a particular type of intervention. So the SPRINT study was a randomized controlled trial, large number of patients, over 9,000 patients in their mid-60s, approximately 35% female, about 30% Black, with a mean 10-year Framingham CVD risk of about 20%, so not a low-risk group, and there was cardiovascular disease in about 20%, with mean baseline blood pressure at randomization of approximately 140 over 78. Subjects with a greater than systolic blood pressure greater than 130 and increased cardiovascular risk, but were not diabetic. They were assigned to either low systolic blood pressure, less than 120, they termed this the intensive treatment group, or systolic blood pressure of less than 140, which was the standard treatment. And the primary composite outcome was a combination of myocardial infarction, other acute coronary syndrome, stroke, heart failure, or death from cardiovascular causes. And you can see mean systolic blood pressure at year one. In this arm, the standard arm was about 136.2 millimeters of mercury and pretty stable. And they were successfully able to get the blood pressure in the intensive arm to a target of around 120 millimeters of mercury. And you can see this difference sustained over a long period of time. If you look at the difference in outcome, you can see there was a 25% reduction in the primary outcome, this composite cardiovascular outcome. But there was benefit with respect to all MIs, although it was not statistically significant. There was no difference in non-myocardial infarction, acute coronary syndrome. There was a mild or modest difference in all stroke. There was a very significant reduction in all heart failure events and in cardiovascular death, which was very highly statistically significant. So clearly for the primary composite outcome and for heart failure and for cardiovascular disease, there was a really impressive reduction in the events. There was a clear benefit. And this can be seen here for the primary outcome. You see the difference between standard treatment shown in blue and intensive treatment shown in orange, clear difference. Death by any cause, see the difference. And when you look at the forest plot, there's a benefit for virtually every type of group of patient, demographic, as well as patients with or without prior chronic kidney disease and with or without prior cardiovascular disease, and whether they were African American or not. So the summary for SPRINT was that there was a rapid and sustained difference in systolic blood pressure that was achieved between the two treatment arms. The trial was stopped early due to benefit after a median follow-up of 3.2 years. But that the incidence of the primary outcome of composite of cardiovascular events was 25% lower in the intensive arm compared to the standard arm. So in the arm that aimed for blood pressure less than 120 and achieved a blood pressure approximately 120 systolic versus the standard arm where the blood pressure was more in the 130 range. And the mortality was reduced by 27%. And the treatment effect was similar in all 6 pre-specified groups of interest that I shared with you. Now, there are some important take-homes. The number needed to treat. So the number needed to treat to prevent the primary outcome or death was 61 in the intensive treatment versus 90 in the standard treatment. So it's clearly beneficial in terms of a meaningful outcome with respect to the number needed to treat. In patients with CKD at baseline, there was no difference in renal outcomes. So it's from a kidney perspective, you don't get more kidney failure if you treat aggressively. In patients without without chronic kidney disease at baseline, the incidence of a GFR reduction of greater than 30% was more common in the intensive group. So in patients without CKD, there is a risk of increasing the creatinine presumably because you reduce perfusion to the kidneys by reducing pump pressure. But there was no overall difference in serious adverse events between the treatment groups. The serious adverse events that did note that are meaningful were some hypotension, syncope, electrolyte abnormalities, and hospital discharge reports of acute kidney injury or acute renal failure, which was more common in the intensive group. But overall, net, there was much greater benefits of more intensive blood pressure lowering in these patients, and that this exceeded the potential for harm. Now, the intensive versus standard blood pressure control was looked at in February 2019 in a paper in JAMA. This was a secondary analysis of SPRINT. These were patients that they evaluated that were aged greater than 50 with hypertension, but with no prior history of stroke or diabetes. There were about 8,500 of these patients, about 91% of the total cohort, and they had follow-up with cognitive assessment. The median follow-up was 5.11 years. And what they found was that there was less probable dementia in the intensive arm versus in the standard arm. This was not statistically significant, but there was a strong trend, so about a 17% reduction. They also looked at intensive blood pressure reducing the risk of mild cognitive impairment. This was statistically significant with about a 19% reduction, and a risk of the combination of mild cognitive impairment or probable dementia, again, was statistically significant. Here, the risk reduction was about 15%. So there are benefits in addition to cognitive impairment and probable dementia, with benefits with reduction in more aggressive reduction in blood pressure in those over the age of 50. So the summary for case 2, his systolic blood pressure can be further reduced to a target of less than 120 millimeters of blood pressure. Case 3. In this case, this is an 85-year-old woman who's seeking a second opinion because her primary care physician has advised her to take lisinopril hydrochlorothiazide, this combination, to lower her blood pressure. She only takes otherwise multivitamins. Her clinic and home blood pressures over the past 2 years have ranged between 158/60 to 180/72, consistent with isolated systolic hypertension, ISH. She has no diabetes, MI, or stroke in her past history, but her mother died from a stroke at age 77. Her blood pressure is 172/65 in clinic. She has no edema. She has normal kidney function, or normal creatinine at least, with a creatinine of 0.8, but her urinalysis is negative. So the options are, you should advise her that A, she should have a 24-hour ambulatory blood pressure measurement done because she likely has white coat hypertension. B, isolated systolic hypertension is, quote, normal with aging and requires no therapy. C, although isolated systolic hypertension should be treated in most patients, there are no data pertaining to women of her age. Or D, taking this combination of lisinopril hydrochlorothiazide may reduce the chances of dying and or developing congestive heart failure during the next 2 years. You have to choose one of these options. So the correct answer is D, taking lisinopril hydrochlorothiazide may reduce her chances of dying and or developing congestive heart failure during the next 2 years. And this, as I will describe to you in a few minutes, is really what has been demonstrated in a very important randomized trial called the HYVET trial, published in the New England Journal. What about the other options? There is really nothing there that supports clinically the idea that she might have white coat hypertension. Her blood pressures, both in clinic and at home, have been in the hypertensive range. It is not true that isolated systolic hypertension is normal. That used to be an old view, but it's not true. It's not true with aging. People used to say your blood pressure rises as you get older because your arteries are harder. Don't worry about it. Not true anymore. And it does require therapy, and as we'll discuss. And C, isolated hypertension should be treated most. There are no data. That's not true, because as I share with you, there is now a fair amount of data, particularly data from the HYVET trial. So this is the HYVET trial, Hypertension in the Very Elderly trial, published by Beckett and co-authors in the New England Journal of Medicine in 2008. The objective of the trial was to determine whether treatment of systolic hypertension in patients over the age of 80 years lowered the risk of stroke. It was a multi-center, randomized, double-blind, placebo-controlled trial. You don't get anything better than this in the trial world. They enrolled 3,845 patients, both men and women, over the age of 80. The mean age of people who were enrolled at baseline was 84, and they all were enrolled with an entry criteria that must have a sustained systolic blood pressure of greater than 160. The treatment in the intervention arm was stepped treatment, thiazide, then add in an ACE inhibitor, and the goal was a systolic blood pressure of less than 150. Remember that goal. Goal was less than 150, and they compared that with placebo. Follow-up was 1.8 years, but the trial was stopped early because of the results that they reported. And the endpoint was fatal and non-fatal stroke. These are the outcomes. You see the graph here. This is percent reduction from 0 to 80. And here in the numbers shown with each of these columns is the reduction, right? And you see that there is a reduction in fatal stroke, which is statistically significant, a 39% reduction in that, a reduction in congestive heart failure, a 64% reduction, which was highly statistically significant, and a reduction in all-cause mortality, which was also about 20%, was also statistically significant. So clearly there's a benefit in multiple domains: stroke, all-cause mortality, and heart failure. So the question then to ask is, systolic hypertension in oldest adults, in the 80s, is fine, all very well, but some of these patients are really quite frail. Should we be treating them as well? And the question then arises from that, whether cardiovascular benefit with treatment of in patients with high systolic blood pressure may only really apply to patients who can tolerate the reduction of blood pressure. In other words, healthier older adults. What has been documented is that higher baseline systolic blood pressure was associated with less decline, physical and cognitive, in studies that have been done in the past. And so, and that makes sense that you might need a higher pump pressure to perfuse the brain, and so you get less cognitive decline. And you could argue that HYVET was done on healthy adults. And so what about a more heterogeneous group? Can you generalize the results of HYVET to all older adults? Also, control of blood pressure is difficult and has many side effects. So can you argue that really, be careful and cautious in these patients? And then relatedly ask the question, do frail older people get the same benefits from blood pressure treatment as healthy older people? In other words, should all hypertensive patients, particularly very elderly hypertensives, be treated the same? Is a cookie cutter approach justified? So this paper that was published in the Archives of Internal Medicine in 2012 is titled "Rethinking the Association of High Blood Pressure with Mortality in Elderly Adults: The Impact of Frailty," published by Odden and co-authors. It was an observational study. That's important to note, observational study. So not as pure as a randomized controlled trial, but nonetheless, hopefully will provide important insights. An observational study done to help determine if frail or healthy adults, that their status, if you're frail or healthy, rather than age alone, may determine who benefits from treatment for high blood pressure. In this study, greater than 140/90. And they determined frailty by walking speed. They divided the people enrolled in this study into slow or fast walkers. And they determined this by the ability to walk 0.8 meters per second, or 75 feet in 30 seconds. The study comprised of 2,340 people, or patients or individuals. Mean age was 74, over the age of 7 years. They followed them, the data was over the, not age of 7 years, but over a 7-year period. What they found or observed was 589 deaths from 2,340 individuals, and they recorded an association between blood pressure and mortality that varied by walking speed. Among fast walkers, these individuals had fewer comorbidities, and those with higher blood pressure, so among faster walkers who had fewer comorbidities, those with higher systolic blood pressure, there was a higher risk of death. So among the fast walkers, blood pressure, particularly high blood pressure, was a major influence on this risk of death. But in slower walkers, neither higher systolic blood pressure or diastolic blood pressure was predicting death. So in other words, among the faster walkers with fewer comorbidities, there is the possibility that lowering the blood pressure from higher to lower might actually result in a lower risk of death. Among those who could not complete the walk test, elevated blood pressure strongly associated with lower risk of death. And so there was this inverse, sort of almost like a U-shaped relationship. The ones who could not complete the walk test, really frail people who had elevated blood pressure, and those individuals, in fact, paradoxically, these people had a lower risk of death. So they needed that elevated blood pressure to reduce their risk of death. So the conclusion is, from this study, was that higher systolic blood pressure was associated with increased risk of mortality only among older adults with medium to fast walking speed. In contrast, slower walking older adults had no association between high systolic blood pressure or diastolic blood pressure and mortality. And that blood pressure strongly associated with lower mortality risk in those not completing the walk test. So in other words, a reasonable take home is that frail adults need higher systolic blood pressure to perfuse vital organs and should be treated less aggressively. Now, in an article in Circulation Research published in 2019, looking at blood pressure in elderly patients, the key conclusions or key messages were that systolic blood pressure increases with age. In contrast, diastolic blood pressure decreases with age, so you get a widening in the pulse pressure, and that you get, as you age, you get an impaired BP homeostasis, impaired blood pressure homeostasis, and increased blood pressure variability. And so this little schematic on the upper right-hand side is true. Blood pressure in elderly patients, these patients need to be handled with care. So in this case 3, the correct answer would be take lisinopril hydrochlorothiazide in combination. It may reduce your risk of dying and or developing congestive heart failure. And in fact, will also reduce in this patient a risk of fatal stroke. So key take-home messages for this talk on hypertension cases is that self-monitoring and self-treatment measurement should be considered in patients, especially among those patients with resistant hypertension. You should also consider in these patients a polypill when a polypill becomes available, but certainly you could consider combination pills. Target blood pressure in non-diabetic patients with hypertension, particularly those that are young and otherwise pretty functional, should be less than 120/80. Based on the SPRINT trial, the benefits seem to be really very impressive. And treating hypertension in very elderly over the age of 80 is associated with a reduced risk of fatal stroke, heart failure, and death, but that it is important to assess frailty in elderly patients with hypertension. And really, you ought to be cautious in frail patients. And as I said, as we discussed, use a walking test as a very perhaps you could argue relatively simple test, but it is an important predictor of frailty, and so consider using it. Somebody who can walk into your office and sit in a chair is certainly going to be less frail than someone who comes in a wheelchair or uses a walker. Thank you very much.